Good afternoon, everyone. So now we begin the next session of Think Under the Apple Tree. And I request the participants to please stick to their time limit of 6 minutes and we'll have a discussion of 2 minutes. I welcome our chairpersons and the judges. And I begin, we're already running late. So I'll ask by inviting the first speaker, that is Dr. Kavanjit Harjot Madan, and she'll be speaking on the development of a predictive model for achieving zero failure rate in macular hole surgery. In the meantime, I'll just introduce our chairpersons. Dr. Chitra Ramamurthy is the chairperson, co-chairpersons Dr. Santosh Mahapatra, and the judges are Dr. Vaishali Lalit Une, Dr. Nand Kishore KB, Dr. Vineet Ratra, Dr. Srini Edekolon, and Dr. Sunaina Malik. So thank you all for your presence here, and with that I request Dr. Harjot to start with her presentation. We'll have to skip the introductions. There's no time.
It's not connected. It's not moving. Udhar. I know what to do. I'm so popular with the audio visual thing.
Yeah, yeah. Okay.
इस पे आने लगा
किस नाम से यही है?
कन्वलजीत मदान ये रहा नीचे 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 से दूसरा
ये।
हाँ जी
What to let go?
क्या करूँ यार
Hey, I say you're good.
मूव नहीं हो रही स्लाइड उधर नहीं एक मिनट वो आ नहीं रहा उधर
टेक कर दो।
Good afternoon, everyone. I shall be discussing development of a predictive model for achieving zero failure rate in macular hole surgery with no financial disclosures. Macular hole was first described by Knapp and classified into 4 stages by Gass. Kelly and Wendell did first of all vitrectomy. Causes could be trauma, myopia, or VFT. These are the 4 stages of macular hole. And in surgery, we do removal of the vitreous, posterior hyaloid, ERM, ILM, and use of adjuvant techniques is done. In our center, we did a retrospective study on 107 eyes of 107 patients, and sutureless vitrectomy was done in them for full thickness macular hole. And we studied best corrected visual acuity, fundus photo, OCT. And on OCT parameters measured were stage of macular hole, height, base diameter, minimal diameter, macular hole index, diameter hole index, tractional hole index, and hole form factor. And we observed that the mean age of the patients was 63.28 years, 71 were females, and the patients were followed up for 9.2 months. And 71 patients, they had grade 4 macular hole. The visual acuity increased from 636 to 618 post-operatively. 101 patients, they had type 1 closure rate. And we observed that when the macular hole index is less than 0.3 to 0.35, if we do conventional procedure, the holes remain open. And if it is more than 0.35, the hole will be closed by conventional or ILM flap procedure. And in tractional hole index, we observed that if the value is less than 0.6, and if we do conventional procedure in them, there was type 2 closure of macular hole. And not a relevant association was seen with hole form factor and diameter hole index. And if we do whether the ILM flap or conventional procedure, the hole will remain closed post-operatively. So based on results, we have developed a predictive model on the OCT parameters which indicate that tractional hole index and macular hole index, they have strong correlation with surgical outcome. And if MHI is less than 0.3 and THI is less than 0.6, they need ILM flap procedure. So based on this model, we did a small prospective study on 31 patients. 4 patients, they had MHI less than 0.35, and 7 patients, they had THI less than 0.6. ILM flap was done in all, and rest of the 20 patients, they underwent conventional surgery. So type 1 closure was seen in all these cases. So it is a very simple model to achieve very good anatomical and functional results and in the macular hole patients. And if MHI is less than 0.3 and THI is less than 0.6, the patients need inverted flap procedure. Thank you.
Judges, questions, please. You can call the next speaker, ma'am.
I think that's fine.
Okay.
So
Thank you, ma'am.
Good
Thank you so much.
presentation. And I would request Dr. Chitra ma'am to please present you your certificate.
The next speaker is Dr. Dipti RH. She'll be speaking on biological cleansing of ocular surface for collagen regeneration.
Good afternoon all. I will be talking about biological cleansing of ocular surface for collagen regeneration in keratoconus patients. No financial disclosure. So as we know that keratoconus is an inflammatory progressive.
Be louder.
As we
Take
Yeah.
off your mic.
Is this better?
Take both up.
So as we already know that keratoconus is an inflammatory progressive corneal disease. So there are many modalities that have been done for halting the progression, and corneal cross-linking is one of the most commonly done methods. Many outcomes can be expected, including excessive corneal haze, corneal flattening, or continued progression can be seen. And scouring through literature, what we found was inflammatory markers like MMP9, IL-6, and TNF alpha are involved in the inflammatory stress that is seen in keratoconus. So we found out that cyclosporin and trehalose, which acts at these respective places, being an mTOR inhibitor, number one, and trehalose being an inhibitor for FAGO4. This can be utilized in keratoconus to prevent the inflammatory status from increasing, as mentioned in the previous slide. So our research question was to find out if we can modulate this inflammatory stress to stabilize keratoconus. So we did an in vitro and an in vivo study. In an in vitro study, we used the human corneal epithelial cells, and with trehalose and with cyclosporin, we tried to find out if it modulates the stress that was seen. And using the lysosome tracker, we were able to finally come to a conclusion that these drugs, trehalose and cyclosporin, are able to reduce the inflammatory stress. So we also did an in vivo study where we chose 90 patients who were mild to moderate KC, and we divided them into two groups, which got a non-targeted therapy or a placebo therapy and a targeted biomarker therapy. So we used the biomarker kit, which is a proprietary tool which measures about 8 biomarkers. Amongst them, MMP9 and TNF alpha were the two markers that were mainly involved in keratoconus. And after finding out that those patients who had higher levels of MMP9 and TNF alpha, they were given targeted treatment, that is trehalose and cyclosporin. And reassessment was done at 8 months, both topography and epithelial mapping, MS39, and polarization sensitive OCT, which is a custom-made model that was done at our institute, was done to analyze if there's any progression of keratoconus. So in the patients which received group 1, that is non-targeted therapy, about 64% of the patients progressed compared to group 2, where only 12% progressed and 88% were found to be stable. And even the MMP9, TNF alpha, and IL-6 levels on the second visit had drastically decreased, which was statistically significant. So even on topography, we found that there was flattening of the cone and pachymetry was stable. And we also had a custom-built PSOCT machine, that is polarization-sensitive OCT, which measures in vivo collagen imaging, and it uses the principle of birefringence. And even on that, we found that the collagen was stable. So in conclusion, the innovation in our study was usage of simple drugs like trehalose and cyclosporin can be used to halt the progression of keratoconus at a molecular level that can be deemed as biological cleansing. Thank you.
There is good logic in what you say, but were these young patients who were analyzed or older patients who were anyway not going to progress in the keratoconus? That is a question.
Ma'am, we chose patients who were mild to moderate keratoconus, so we did
Yeah.
not choose those who had advanced KC
Yeah.
because they would inevitably require a surgical intervention.
Any particular strength of trehalose, and that's the number one question. Then second thing is, how long was the stability maintained?
Yes.
How many did you have to go in for subsequent procedures?
Yes. So we chose sodium hyaluronate 3% with trehalose 0.18%, cyclosporin of 0.09%, and it was instituted for a total of 6 months. And then we reassessed again. So that's sodium hyaluronate. So trehalose cannot be given individually, so we had to reconstitute it with sodium hyaluronate.
Thank you.
Thank you.
Well spoken.
Thank you.
I request Dr. Sunaina Malik, ma'am. Take your certificate, please. So our next speaker is Dr. Hirika Vipul Gosalia. She'll be speaking on D-igram, a foldable stencil.
Yeah, so good afternoon, everybody. I'll be talking about a pocket-friendly stencil for all, D-igram. So the problem statement here was, as we all know, documentation is the cornerstone of clinical science. It's a lost art now, rarely practiced now. And most find it time-consuming. It's very prevalent amongst juniors and senior clinicians. Mainly, this helps us to document the pathology in a more detailed manner as compared to a clinical photograph. So why is documentation really necessary? Is it necessary? Yes, it is. It's a standard clinical practice worldwide. Follow-up is possible only if you can compare it with previous records. Will help you medico-legally. Important for resident training, teaching, and during their examination. Allows you to accurately describe the size, depth, and location of the lesion. Last but not the least, unless you're documenting it, you have probably not even seen it correctly. Do you really know what break you are actually seeing, which clock hour it is in? Unless you document it, you're not really sure what you've seen is correct. So what we are using nowadays are these stencils which don't have the proper ophthalmic diagrams, the bangles, and the compass that all students are using in examinations. So the current problem is time consuming. It doesn't justify the standard ophthalmic diagrams. Slit cornea views, anterior chamber angle documentation is not achieved. So that's when I came up with this prototype. We did a 3D printing, and we came up with these designs which would be very helpful. This is pocket friendly in a keychain manner, showing most of the important diagrams that we need for documentation. So the uses and applications. So this is for the cornea, wherein the slit and the whole cornea slit and front view can be documented. This is for the squint evaluation and oculoplasty related evaluation. It's for angle of anterior chamber related. This is for ROP zones documentation. This is the cross for the retinoscopy and also can be used for gonioscopy. These are the pupil diameters on the side ranging from 1 to 10. And these were the basic prototypes that we have come up with, which is pocket friendly. And this for retina. so would want to come up with a more foldable stencil type of prototype, introduce more designs which can be specific for any disease, like for a corneal ulcer, come up with shapes and size showing DM folds or probably edema and epithelial defect. So it's a pocket-friendly essential documentation tool for resident training, essential exam tool for ROP training and screening, and a follow-up tool. Thank you.
I have a question about your this
Yeah.
one for the squint. How do you do this?
No. It's
How will
just
it work?
just to show a basic exotropia in like just for examination while writing
Just
for
to draw the eye,
yeah.
just to draw the
Yes.
palpebral aperture.
Yes. I'm not saying all of it is necessary, most of it is, but because we are making designs, we try to make more designs for all the different specialities.
I think, but it needs a lot
Yeah,
more
improve.
refinement.
Yes. This is a
Yeah.
very basic, I've not even
Yeah,
brought
this
it
is
out.
right.
It's
But
a very
it's
basic.
a good idea.
Yeah.
It's a good idea, especially for residents.
Yes.
I would recommend that they use it, particularly the one where you showed the ROP. zone.
Yes, exactly.
That is very good.
Yes.
Could have a cornea.
But don't you think having these pictures ready-made on a sheet
So
is less time consuming as compared to taking out these?
that's true, sir. First of all, not everybody has accessibility to EMR. We are still talking about medical colleges where they are still doing paperwork. And also, as resident, I feel it is important that we learn the diagrams first and not directly jump into pictures, because documentation of every sign is very important to learn it. Even for examination, we are not going to take a picture along with us. So even for follow-ups, if we can show the size of the epithelial defect decreasing, and if we keep doing it, the reason they are not doing it because they don't have a tool which is helping them. They will be like, why it's so time consuming? But if we have something in their pockets where they can do it regularly in the OPD while they are seeing a patient, I think it would be great.
Yeah, I do accept for residents it's fine.
Yeah.
But as a process of documentation, I think it makes more sense to have these
Photographs.
diagrams so that it's less time consuming and much more easier.
But I think I agree with you that for the beginners, for residents, this is a very good tool to
Yes.
get them used to documentation. They
Yes,
can
ma'am.
take pictures later on, but in the beginning, let them at least.
Yeah, I think that's a learning step. I mean,
Yeah,
we cannot directly jump into
absolutely.
slit lamp photographs, and not everybody has a nice
Has
slit lamp
access to all those
photography.
tools.
Yes.
Right. Good.
Thank
You
you.
could include a corneal section in this
Yeah.
Okay.
also. That's
Yeah,
missing.
the slit. Yeah.
Yeah.
Yeah, the best way to learn is to draw. So yes, that helps, but you get printed sheets also.
Yeah, so we do have, but I'm just saying for examination also. I mean, if you have something which can be used everywhere, printed sheet is something, then again you go and
It's
take
a
this
good
way.
idea. It's
Yes.
a very good
It's
idea.
an alternative. I'm not saying it's not
yeah,
there.
the more
out,
you
but
draw, the more you observe, the more you learn.
Yeah.
Yeah.
Very nice
absolutely. The
presentation,
next, okay,
Erika.
thank you. Take your certificate. 1 minute.
Dr. Nankishu.
I
Dr.
invite
Nankishore.
Dr. Nankishore, please do the honors.
So
And
we
I
can
call the
have
next
Dr.
speaker,
Shetty.
Dr. Panna Shetty, role of lid hygiene on ocular immunology. I would suggest to save time, the next speaker, please be ready. You know your serial number. Please be ready in front. Oh yeah, sure. I thought you were giving that to us.
Okay. Good afternoon, everyone. Today I'll be speaking on the role of lid hygiene on ocular immunology. So, as we know, as our life is progressing and more of technology, screen time, everything, the dry eye disease, which used to be very less actually in incidence, is also increasing. It has come up to 5 to 50%, and from place to place it varies. So, the basics, what we know about it. One, it is an ocular surface inflammation, which may or may not be associated with altered tear film matrix. So what are the current strategies to treat this disease? One, the medical therapy. Second, the procedural therapies. And the third, maybe surgical management. But by doing all these therapies, are we treating it just symptomatically, or the root cause also are we treating it? Because even though we treat it, it does recur back. So we went into little depth to see why it's happening again and again, and we realized that the basic things are it has decreased production, or it may be because of decreased blinking, or there may be a gland dysfunction. So that is all correlated to the lid pathologies. That is the chronic inflammation of eyelids, meibomian gland dysfunction, blepharitis, lid malpositions. So it is very important to treat these lid pathologies. And these lid pathologies not only cause evaporative type of dry eye disease. They also cause an aqueous deficiency also. So both of them together cause a difference in the pH of the ocular surface, causing an altered ocular microbiome. That is the main reason for the recurrence of dry eye disease. So we wanted to our aim was to treat this altered microbiome. And we saw in the literature that there's nowhere discussion about how to treat this altered ocular microbiome. So that's why we went ahead with the simplest of the techniques, that is lid hygiene. Whether that itself can alter the ocular microbiome or not. So 50 subjects were subjected for this methodology, and ethics committee approval is taken. We had done a basic tear matrix evaluation, keratometry and NEBUT was done, and tear film evaluation is done for this. So we had subjected these patients for eyelid wiping for twice daily for a month, which had tea tree oil, virgin coconut oil, castor oil, which is all helpful in the lipid film betterment. And in the results, as usual, first we did the tear film matrix. We saw that the lipid layer had improved with the help of just lid hygiene, just simple lid wipes. Even the NEBUT had improved. Coming to the ocular inflammatory biomarkers, with the help of our biomarker pathfinder kit, we found out that without the use of the lid wipes, there was no improvement in the biomarkers. Whereas if you use these lid wipes, there was some amount of improvement even in the inflammatory biomarkers, especially that is MMP9, IL-6, TNF alpha, and IL-17A. So as these are the markers that are also responsible in post-operative haze, we have an ongoing study right now where we want to use these lid wipes pre-operatively in refractive surgeries and cross-linkings, so that we can reduce all these inflammatory biomarkers and hence reduce the possibility of haze itself. So as per our paper, we know that increased amount of TNF alpha, IL-1 beta, MMP9 and TGF beta are the responsible factors for scar formation. So with the help of these simple lid wipes pre-operatively itself, we can reduce the haze. That is the theoretical basis of it. We are still working on this. So take-home point is complex problems often have simple solutions, and this is one of a kind of a study where the lid hygiene is being studied to alter the ocular immunology. Thank you.
Thank you. What brand are these lid wipes?
There's no financial interest in this, but we have used Tizzy lid wipes for this study.
Simple lid wipes means
Tizzy
what?
lid wipes, yes.
C.
T-I-Z-Y.
C-I-Z. Okay. Thank you.
Thank you.
1 minute.
Yes, sir.
You said pre-operative use.
Yes, sir.
How long does that effect sustain if you use just pre-operatively? Because I think haze is an ongoing process.
Ongoing.
And usually you see it after 3 weeks. So how long, I mean, just a pre-operative wipe, do you think it really helps?
So, sir, very good question, sir, actually. So, we also wanted to see that. That's the reason we did the study. And we observed that since that 1 week itself, the inflammatory biomarkers did reduce. So, nowadays, we are using in our patients, like we pre-operatively itself have started giving them the simple lid wipes, at least to use them 3 days before surgery. It will not reduce it completely down, but some amount will go down,
Yes,
no matter
yes.
what happens.
We also use lid wipes in our practice for our patients, so
Yes,
it
ma'am.
does help.
Yes, ma'am.
But maybe combining it with pre-operative, maybe after the,
yes, sir.
1 week when the epithelial regeneration
Yes,
is
sir,
complete, then you can probably continue that.
We do continue, sir. It's post-operatively also used, sir.
The role of oil,
Sorry, ma'am?
the role of oil in these wipes.
So they help in dry eye disease, the tear film matrix itself, it helps. That is, the lipid layer is increased. Secondly, it also kills the germs and all that is there, ma'am. Because of the blepharitis and all that's caused, it does kill the germs and all and alters the microbiome.
Does it have any antimicrobial property?
No,
Little
there-
bit, yes.
there
The
is an
castor oil that is used.
There's an inflammatory cascade triggered by these excess of lipid proteins. So if you wipe them off, then that inflammatory markers go down. That is not the only contributor, it's just one more addition. along with topical steroids, along with lubricants, along with dark glasses, all of this.
My question for your ongoing study, which is for operative patients, if you ask the patients to wipe after surgery, isn't there a danger that they might harm themselves?
Very true, ma'am. That's the difficulty we are facing. But we do educate them after surgery. We have a counseling session with them that how to use these lid wipes. Because when they don't use the lid wipes, we have seen many times that the medicine, the drops and all will be stuck to their eyelids. That will cause an infection in the future. So instead of that, we do educate them to use the lid wipes.
Are these sterile?
Yes, yes, they are sterile.
Lid lights. You just open it and
So I request Dr. Santosh Mahapatra to kindly give the certificate to Dr. Panna. And sir, you can call the next speaker.
Can we have Aishwari? Is Aishwari there? Dr. Ankur Singh? So I think Dr. Chaitanya is next.
Ma'am, take my pen. I'm not using it. Sure, sure.
suddenly my mind is, no, you will protect me.
Very good afternoon, everyone. So, I'm going to talk about breakthrough in pediatric retinal imaging, rather expanding the platform of MIOCT to pediatric patients using exo-illumination technique. So, as we are aware that optical coherence tomography is a vital diagnostic and a therapeutic surveillance tool for wide spectrum retinal choroidal pathologies. Conventional table-mounted OCT are not designed for infants or young children. Portable handle OCT, although designed with appropriateness for infant and children, suffers from problems like image loss, and there is additional high equipment cost. MIOCT is now becoming a very important intraoperative armamentarium for retinal as well as anterior segment surgeons, but requires invasive ocular image requires invasive intraocular illumination for image acquisition. Can the benefit of the MIOCT be transferred to these uncooperative infants and young children without the need of invasive intraocular illumination? That was the question we need to answer. So this study describes and assesses the efficacy of exo-illumination MIOCT technique for non-invasively obtaining retinal OCT images in children undergoing examination under anesthesia. So this was a prospective study, observational study carried out at Advanced Eye Care Center, PGI Chandigarh. 10 consecutive pediatric patients with suspected posterior segment pathology, uncooperative for retinal choroidal imaging on conventional table-mounted OCTs were taken into the study. The outcome measures were total image acquisition time, that is the time from the beginning of the OCT machine, the switching on the OCT imaging, and till the end of the procedure. A second outcome measure was successful acquisition of interpretable vitreous retinal choroidal OCT images. So how this was done? So what we did is we used a simple endo light. We placed it at the limbus. The light passed through the cornea lens and reached onto the disc. Once the disc was visualized, we switched on the MIOCT machine. The MIOCT machine was switched on. It could visualize the disc. We optimized the layers of the retina with the inbuilt optimization software. Once the disc image was achieved, we moved the crosshair to the area of interest, and this is how images were achieved. So different size scans were used, and they were all recorded and compared with each other. Two different surgeons performed the same procedures so that we can observe the intra-observer variability. MIOCT, which allowed the delineation of all the structure, all the layers of the retina, were considered as good quality scan, while those in which the layers could not be delineated was considered as inferior quality scans. So both the surgeons could delineate the foveal microstructure in all the 10 eyes using our novel exo-illumination technique. All images acquired had a good spatial resolution and were good quality images. However, I would like to inform that the exo-illumination technique did not work in one case that had X-linked retinoschisis with inner retinal equatorial break. So any lesion which was at the equator or beyond that and anterior to that could not be scanned with our technique. So this is the list of patients. So optic disc, fovea and parafoveal microstructures were best seen with 4 by 4 mm scan, while 16 by 16 mm scan were used to localize the area of interest as well as allowed us to give us the overview. So look at this image. So what you see is a pediatric patient that came to us with an RD. We use the illumination techniques, and we know that patient has an RD clinically, as well as we can quantify the macula is detached. The same patient underwent buckle. During the buckling, when we did an SRF drainage, initially we know that this is how much the fluid is left. We drained him further, and then we intraoperatively, without going into the eye with the help of the endolite, we could see that the retina is well approached. The total time taken in this procedure by both the surgeons was around 3 minutes 25 seconds roughly. And how this, the conclusion for our study is that axial illumination technique can effectively provide invaluable microstructural information during EUA and can augment the findings obtained by clinical examination of the pediatric patient. This technique expands the platform of existing MIA-OCT indication, preventing additional expenditure required for an handheld OCT. However, we need to understand this machine also has a limitation of conventional OCT, that is, we cannot image beyond the equator. Thank you.
So by manipulating the eyeball also you could not image the area beyond the equator, or could you?
Ma'am, so what happens is that whenever we manipulate the eye, there is a diffraction of light happening. So diffraction of the light loses the image quality. If we could do this, it's just the same technology. So if you try to, if you try to take an image of an infant on an Optos or an OCT, and you try to give him a face tilt, your image quality goes down. So although you might get a fundus picture, but you will not get a good OCT. And OCT is good enough only when it gives you complete spatial resolution of layer by layer. So you might get an image, but can you identify the disease is the question.
You could not see your OCT machine in the photographs you have shown.
Yeah.
Which machine you have used?
So this was a Zeiss microscope resight. The machine that is used in this study was the Zeiss with the resight. Resight is the intraoperative OCT of the Zeiss.
Integrated. Not shown it.
Ajay,
but your pictures didn't show it.
The resight is the viewing system. What is the OCT? The resight is the viewing system, right? So the OCT is integrated.
I think this is incorporated
is
to
integrated into
yeah.
that viewing system.
It's a Lumira 700 system with inbuilt OCT
with
and the
inbuilt
resight.
OCT, yes. Okay, and what was the general anesthesia or ketamine or what?
Ma'am, it's for GA. All the patient
Full
who see,
GA.
yeah. So
it just took 3 minutes, so you could just have given a short acting ketamine or something.
So ma'am, what we were thinking is that this study was done in PGI. PGI still don't have an handle OCT, additional expenditure. Even it's a top tier institute of the country. So how can we expand the platform? We had an MIOCT, AIMS has an MIOCT, PGI has an MIOCT, many other institutes has MIOCT. Sir, this was part of the EUA. So this was not, we did not do an OCT per se. EUA that was being done, we just did an OCT.
Okay. Dr. Vineet Ratra, I request you to please present the certificate to Dr. Ankur Singh. Next, you can announce. You can announce the next one. Dr.
The next is Dr. Chaitanya Arvind Ankem. Are you ready, Dr. Chaitanya? Yeah, please. And after that, Dr. Arvind Kumar Maurya, please be ready for your presentation. Thank you.
Small video that I wanted to demonstrate. So just waiting for the volume. 1 minute. Volume. नहीं आ रहा है. 1 minute. यहाँ पे तो यहाँ से भी वॉल्यूम फुल है. Yes, ma'am. I'll figure out the audio. Should I put
Dr. Arvind, if you're ready, can we have, yeah.
So good afternoon, esteemed judges and my dear friends. So I will be speaking on our innovation, that is the Terrigo scleral BCL. That means the pterygium is gone for forever, and there are other indications also. And so there is no plasma blood is required, there is no glue and no suture, of course. So this is how it looks. It is 21 millimeter diameter hydrogel. And if you compare it with the corneal BCL, this is how it looks, larger size. And this comes in this form, silver nanoion emulsion. So even if the viral load is in the millions colony forming unit or the pseudomonas, they die. So that is the importance of using this suspension of silver nanoion. And this is how it is. I'm removing it from the packing. And we require 4 hands in this. So with the help of my assistant, I'm opening it, and this is how it fits well. And even we can, if the graft is little bit overriding, we can manipulate through this scleral BCL hydrogel. And this is after 1 day. You can see the healing is already started. And this is after 7 days. Very good healing. So what is the advantage? It covers all the 3 sides, the donor area, graft, as well as the corneal epithelial defect. So more than 3,000 cases, no recurrence, and the clinical trial is going on. So when we compared it with the glue and with the sutureless and glueless. So the recurrence is 0% in this group, whereas it is 5% in the glue as well as the sutureless and glueless. So it is very simple cut and paste kid's job. The surgical time is only 5 to 10 minutes, and these are the other indications. So especially the after K Pro eyes, they works very well. And now we have customized these BCL also for the aphakic patient. The toric version is also it's already FDA approved. So there are a lot of indications. Thank you so very much. I'm free to take any question. And the water content is 75%.
Thank you.
Dr. Arvind, is this your regular BCL? The regular bandage?
No, it's different. It's 21 mm size. So even there is double, if the pterygium is nasal as well as the temporal, still it covers all the sides. That is the advantage.
And in your video, I've noticed one thing, that the graft was turning a bit under the contact lens.
No. I have shown that we can manipulate after putting the this BCL also. So
Going
that's
inside.
why I show that we can manipulate if the BCL is over that.
Okay, thank you.
Is it customized for each patient, or
Sorry?
Is the BCL is customized for each patient, or is the diameter is fixed?
It can be customized also. The standard size is 21 millimeter diameter. It can be customized, yes. Silver Line, Delhi only, Malvi Nagar, Delhi. And we have no financial interest. It's available in 1,500 rupees only cost. No financial interest.
How long do you leave the...
As per the US different PubMed studies, we can keep it up to 3 months.
Do you take any...
No. Reuse, no.
Apart from pterygium, you can use it for any other indication?
There are 12 indications. I have shown after K Pro, Varun is using, Dr. Hunawar sir is using after the OSS and removal. So it's working so well because the water content we have kept is 75%. So there is very rapid healing.
Thank you, Dr.
You
Moria.
said 3 months.
Yes, 3 months.
Do you take any special precautions to prevent infections when a BCL is there for such a long time?
Yeah, the preservative-free antibiotic that needs to be there. Yeah.
When would you?
In after pterygium, after 1 week. Yeah.
I request Dr. Tinku Vadi to hand over the certificate to Dr. Moria. it Chaitanya ready? Yeah, please start.
So this is a video demonstrating how you can revamp and rewire your whole OT to make it completely automized. So mainly I've designed this because there is shortage of skilled OT assistants, and every time you need to train the new person to do what you wanted to do. And I, being a new surgeon, I wouldn't have that much support
Hi,
staff.
my name is Dr. Chaitanya Aravindankam. Today I am here to talk on the topic of surgical synergy, where you have an OT assistant for being a smart AI assistant. The main problem with today's individual practitioners is your OT assistant might not be skilled, or you do not have enough OT assistants at the right moment. So I have programmed my entire OT with voice commands, as it will be much easier for surgeons to do with voice commands. So let me show you how the first voice command is designed into the OT. So let us see how everything comes to life with this one simple command. Alexa, start theater. Okay. So with just one voice command, you can switch on the lights, your microscope, your retro illumination, your TV and video recorder, above that. Here I am simulating the surgical scenario, and here is the view through our 4K surgical camera. So here I am simulating a surgery, and to cut the glare from behind, so I use this command. Alexa, turn off backlight. Okay. This turns off the light that is causing a retro illumination. So I will use this command. Alexa, now I want to record my video or live stream my video directly to YouTube. So I'll use this voice command. Alexa, start recording. Okay. Alexa, stop recording. Okay. Suppose you want some help from outside the OT, or you need to call a person, you can use this customizable commands. Alexa, turn on. While you are doing the surgery, if you want to control your phaco machine parameters, or your foot pedal switches fails over time, you can always customize with voice commands. Alexa, previous mode. Okay. Alexa, suppose you want to change some certain parameters in the phaco machine while you're operating, you can do it with just for voice command. So you can say like, Alexa, increase bottle height. Okay. Alexa, you can even say like, Alexa, you can say like, Alexa, increase vacuum. Okay. Okay. Alexa, Alexa, Alexa. So that is done. You can completely turn off all the equipments and devices in the theater with just simple customizable commands like this. Alexa, stop theater. Okay.
This
Good
you
job.
can.
Good job of using Alexa. Very nice.
So
But
this
suppose
is
Alexa conks off one day, then you're stuck.
so what I did is like the major challenge is internet, and strong internet, and power system in scenarios like South India.
But you have connected Alexa to everything.
Yeah, yes.
Means your phaco machine, the lights.
Yes, yes.
Everything.
There is always a fail switch, like where you can. It's both manually and like with Alexa, both the things we can work. Like if Alexa fails, like, so what I do is like I put a power backup for the router and the Alexa as well, so nothing doesn't fail over time. Sir. Nothing, sir. Just like how we speak in normally, it will take a week or two for to fine tune to your voice. Once it fine tunes to your voice, it only prerequisite is like you are the only surgeon who needs to give the commands over a period of time. So then it will adapt to you, and after that it will work fantastically.
How
But
did
if
you adapt the phaco machine to?
Sir, this is things that we require, sir. Basically, the phaco machine we can work any phaco machine that has a remote control. So all the newer generations have a remote control. So what we do is we'll actually intermit the signal or bypass the signal how the remote control works.
So you connect the remote to the Alexa.
We just duplicate the remote, sir, and we do that thing, and we connect with the Alexa with the voice commands.
Very innovative.
So you can actually, for a well-performing surgeon, you doesn't require much of alterations when it comes to vacuum and power. So when you're at the optimal zone like 300 or 400 vacuum, you require only like 20-30 degrees, or beyond 500 you require little increments, not more than 30. So you can design the program like it's an endlessly, you can write whatever codes you write. It's nothing like, it's just a small app. This is a small app where you just need to write the thing like, okay, if I say this command, increase it by 10 times. If I say this command, send the command by 20 times. Like how many times you want, you can increment it. So those many times, like it works like same way, sir.
Have you dispensed with the use of sterile covers or the phaco machine screens, touch screens and all?
Yes, sir. Yes, sir. It works because it works only how this also similarly sends the infrared signal only. So a disposal cover wouldn't be a problem, sir.
So do you operate without an assistant nowadays?
Only the nursing staff will be there, sir. No other person will be there in the OT,
Okay,
sir.
you mean OT assistant you don't
Yeah,
need?
OT assistant I wouldn't have, sir.
Perfect.
You
I think it's a
collaborated.
wonderful way.
Sir.
Did you collaborate with an engineer like biomedical? Like
No, ma'am.
you did it on your own.
I did it on my own. It took 1 month for me to do the thing.
This app is available on the App Store. It was created for you. Or
No,
you
ma'am. It's everything is available on Amazon. I bought all the things. So these all things are from Amazon. So it
you
costs
set
you
it
less
up
than 20,000 to fix all these things, ma'am. But only thing is you require little more patience to design what you want exactly. Thank you.
Very good.
Sure, sir.
Dr. Prashant.
Yeah, yeah, sir.
You can hold this one to give this Dr. Vishal.
So there is a small thing with Alexa, sir, where you can actually bypass the developer modes and you can confine it to the commands that you already designed. So irrespective of whatever it gets it from the internet across the web, it has every chance to get across it. But again, like the chances of people increasing, how many people gives the commands, again it might go wrong. But only thing is, if you are operating surgeon, it's better only you. This is more designed for an individual practice where a surgeon is the main person who gives the commands. So within a week or two, it will actually adapt to you. So, or if you want more thing, you need to explore the developer options where you need to lock into the only the commands that you feed it. Or you can do some more thing, go a little ahead, and you can do an Arduino board is there where you can actually design the commands. It is completely offline, but it is very expensive.
You are a very good example of how good the younger ophthalmologists are adapting to newer technologies.
Sir,
very, very good.
One question.
Sir.
Whether there is any prohibitory laws like patent laws which you have to taken care of in developing your these devices.
Prohibitory in the sense, sir.
Patent law, the Alexa is not your invention.
Yeah.
Alexa is somebody else's invention.
Yes, sir.
And Alexa invention is probably copyrighted or whatever, patented by the company itself. So, if you do something taking taking the help
Sir,
of
Alexa is already available free of cost. It's a open source. Sir. Like basically,
that's what I
you
am
are paying
asking.
for it, and you have the right to develop it also. You have the option for developers also. So it doesn't restrict you in any way. They can't file anything on you. Because like there are multiple people who are using it for vast number of things. We are the least people who are using it for very low things.
Have you gone through all these things before?
Yeah, yes, sir. Alexa is like completely open, sir. Like they don't do anything.
That's
for
a
you.
different issue, sir.
Okay,
We
that
can
is
discuss
one
it
thing worrying us,
Which
no?
goes-
Okay.
goes is-
Yes.
Okay, thank you. Yeah, thank you. So, thank you. I thank all the respected chairpersons and the judges for their presence here. Any parting words you'd like to say, ma'am?
I'm sure the very fact that so many people are leaving their lunchtime and staying here talks about the respect and the regard they have for this Think Under the Apple Tree session of ARC, which was conceptualized by Partha and very conscientiously taken forward by me and now with Prashant Bhavunkule. I think it just brings out lot of innovative talent of the youngsters. So all the best for this session.
Thank you. I request Dr. Prashant to please give a certificate to Dr. Chitra for being here. Thank you. We'll be announcing the finalists after some time, so please keep a watch out for that.
He's Vinitra. Not in. Next. Requesting all the judges and the chairpersons, moderators, and speakers to come for the group photo.
To Dr. Santosh Mahapatra.
I'll give them to you. Vinitra. And mine, I think, is below that. आपका भी है एक ग्रुप फोटो लेना है लेना है बोला नहीं
मेरा भी है
डॉक्टर थैंक्स
Dr. Vineet Ratra.
I think that is not used. These are the ones which have been marked. And
Dr. Sunaina Malik, ma'am, thank you so much, ma'am, for being here. Dr. Nand Kishore, sir, thank you, sir, for being here. Dr. Vaishali Une.
group photo, come please, everyone.
Everybody to join for the group photo.